Hello. Today we've got a great session sponsored by KDIGO, which will tell us about new insights in the management of hyperkalemia. We've got a terrific panel lined up. You'll hear from Dr. Pecoits-Filho, Dr. Kovesdy, Dr. Sood, and Dr. Deborah Clegg. We'll be starting off with a talk from Dr. Kovesdy, who will be telling us about the fundamentals of potassium homeostasis. We'll then turn to Dr. Clegg, who will tell us about the plant-rich diet and the implications that has for potassium, particularly in our patients with chronic kidney disease. Dr. Pecoits-Filho will tell us about optimising RAS inhibition, targets and optimal kidney protection. And then we'll finish with Dr. Sood, who will tell us about emerging evidence in potassium management. And last of all, we'll have a great Q&A session where I'd invite all of you to send in your questions and any comments you might have, and we'll clear up any controversies. So thank you very much. We'll now turn to Dr. Kovesdy.
Hello, my name is Csaba Kovesdy, and I am the Fred Hedge Professor of Nephrology at the University of Tennessee Health Science Center. I will be discussing with you today the fundamentals of potassium homeostasis. The objectives of this presentation are to review normal potassium physiology, to describe potassium homeostasis in chronic kidney disease, and to examine epidemiology of hyperkalemia in CKD and ESRD. We will first start with a review of normal potassium balance. The average amount of potassium in the human body is approximately 40 to 45 milliequivalents per kilogram body weight, with slightly higher levels in men compared to women. This amounts to over 3,000 milliequivalents of potassium in the body, most of which is in the intracellular space. This next slide summarizes the main factors that play a role in potassium homeostasis. The total body potassium content of an individual who is in homeostatic balance is stable. This requires that the daily intake of potassium, which is about 100 milliequivalents, be excreted. Excretion occurs mainly by the kidneys, which account for about 90% of excreted potassium, with the gut accounting for another 10%. An important point to mention here is that the kidneys have the ability to adjust the amount of excreted potassium based on the amount of intake. In a patient with low intake, the kidneys will typically decrease potassium excretion, while in the case of high intake, the opposite will happen. GI excretion, on the other hand, is relatively fixed, except in patients with advanced CKD and especially those who are anuric, in whom GI potassium excretion increases several-fold and becomes an important component of potassium homeostasis. Another important aspect of potassium homeostasis is the distribution of potassium between the intra and extracellular space. Because of the extracellular space contains only a small fraction of total body potassium, maintaining a normal potassium concentration in the extracellular space requires an ability to shuttle potassium in and out of the cells, for example, to account for a sudden increase in potassium load following a meal. As we mentioned on the previous slide, normal kalemia is achieved by matching intake with excretion, and also by the rapid exchange of potassium between the intra and extracellular space. The ability to maintain a proper distribution of potassium between the intra and extracellular space is important, not only in the grand scheme of maintaining potassium balance, but primarily because the distribution of potassium is a major factor that assures a normal resting cell membrane potential and plays a crucial role in maintaining normal electrophysiologic functioning of the cells. This is especially important for normal cardiac and skeletal muscle function. This slide summarizes in more detail the main mechanisms that assure normal kalemia, showing more detail especially about the factors affecting cellular potassium shifts. As shown on the left side of the slide, movement of potassium from the extracellular space to the intracellular space is facilitated by stimuli such as insulin, beta-2 adrenergic receptor stimulation, and alpha adrenoreceptor agonists. Alkalosis may play a role, but the effect is indirect and may not be a very effective stimulus. The aggregate results of these actions is a decrease in serum potassium concentration, and hence these stimuli are typically used therapeutically for acute management of hyperkalemia. Now, as is shown in this second box, in general, the opposites of these stimuli will lead to a leakage of potassium from the intracellular space to the extracellular space, and this can induce hyperkalemia. Next, let's examine how the kidneys regulate potassium excretion. The fine regulation of potassium secretion occurs along the distal nephron, with several different mechanisms playing a role. As shown in the first little cell here on the left, an electroneutral potassium and chloride co-transport mechanism is present on the apical surface of the distal convoluted tubule. However, the most important cell that is responsible for potassium secretion in the initial collecting duct and the cortical collecting duct is the principal cell. This cell possesses a basolateral sodium-potassium ATPase that is responsible for the active transport of potassium from the blood into the cell. The resultant high cell potassium concentration provides a favorable diffusion gradient for the movement of potassium from the cell into the urine. Both the movement of sodium and potassium across the apical membrane occur through well-defined sodium and potassium channels, which are called ENaC and MaxiK and ROMK channels. In addition to establishing a high intracellular potassium concentration, activity of the sodium-potassium ATPase lowers intracellular sodium concentration, thus maintaining a favorable diffusion gradient for movement of sodium from the urinary lumen into the cell. There are several determinants of potassium secretion in the collecting duct, as we highlight on this slide. First, there is luminal sodium delivery and flow rate, which assure that luminal sodium can be exchanged for potassium. This is reduced in chronic kidney disease and contributes to the development of hyperkalemia. Second is the availability of physiologic circulating aldosterone. Aldosterone binds the mineralocorticoid receptor and stimulates ENaC abundance and an open state of ENaC, which augments sodium absorption, making the luminal potential more negative, thus increasing potassium secretion. An important aspect of this mechanism is the blocking of aldosterone through various drugs, which can contribute to the development of hyperkalemia and which we will review on one of the subsequent slides. Finally, there are two more factors I would like to mention. One is plasma potassium concentration, which inhibits an intracellular signaling cascade, resulting in potassium secretion in the distal convoluted tubule, and also increasing channel density of both ROMK and MaxiK channels in the collecting duct. And last but not least, less known is that circulating vasopressin levels can also stimulate potassium secretion by augmenting potassium channel activity at the luminal level. Now that we examined the physiologic underpinnings of potassium homeostasis, let's turn our attention to hyperkalemia as a clinical entity. Hyperkalemia in persons with preserved GFR is fairly uncommon. With decreasing GFR, however, hyperkalemia becomes more frequent, even though the ability of the kidneys to compensate and increase potassium secretion at a single nephron level is remarkable. This adaptation results in a remarkably stable potassium balance, even in patients with advanced CKD, but only as long as patients avoid rapid changes, such as, for example, a sudden increase in potassium intake or an acute clinical event. Patients with advanced CKD, and especially those with estimated GFRs below 15, become more prone to hyperkalemia in the face of such sudden changes in potassium balance. This next slide illustrates the various mechanisms of actions whereby hyperkalemia can occur. As you can see, these can be grouped according to the disease states responsible for the various mechanisms, such as, for example, decreased excretion in chronic kidney disease and in acute kidney injury, or hyporeninemic hypoaldosteronism in diabetes. Of particular interest are the various drugs that are often used in patients with cardiovascular disease, which are shown in the right lower corner here, and which can induce hyperkalemia through various mechanisms. The importance of this is that several of these drugs have proven clinical benefits, and hence, when a patient experiences hyperkalemia, they are often discontinued, potentially depriving patients of their benefits. One final point I'd like to make about this slide is that in many of our patients with CKD and ESRD, we observe concomitantly more than one of these listed mechanisms, conspiring to induce hyperkalemia, which explains why patients with advanced CKD are considered the highest risk category for this condition. As mentioned previously, drugs blocking the renin-angiotensin-aldosterone system are particularly important in the etiology and management of hyperkalemia, both because of their potency in inducing the condition and because of the clinical importance of these drugs. This slide summarizes the various steps along the activation of the renin-angiotensin-aldosterone system and the various drugs and clinical conditions that could affect these steps. These include, for example, NSAIDs and beta blockers inhibiting renin production, ACE inhibitors blocking the conversion of angiotensin 1 to angiotensin 2, angiotensin receptor blockers blocking the action of angiotensin 2 on its receptor, various mineralocorticoid receptor blockers doing the same on the aldosterone receptors, and finally, the drugs inhibiting the ENaC, resulting in decreased potassium secretion. As we mentioned previously, hyperkalemia is relatively rare in the general population. The studies that examined hospitalized patients and patients in the emergency room put the frequency of hyperkalemia in the general population to about 2 to 3%. The same studies have noted that certain clinical conditions, such as CKD and diabetes, result in increased risk of hyperkalemia, which is not surprising in light of the previously detailed mechanisms. This next slide details similar results from a large cohort of hospitalized patients, showing an incidence of hyperkalemia approximately 2 to 3%. Next, to illustrate the importance of chronic kidney disease as a major risk factor for hyperkalemia, our group has examined the frequency of potassium concentrations above 5.5 and above 6 milliequivalent per liter in a large cohort of patients with advanced CKD right before they transition to dialysis. As shown in this slide, the prevalence of a potassium of more than 5.5 was 25%, and that of a potassium of more than 6 was 10%. An important practical point to make is that when we examined potassium levels longitudinally in the same patients who had repeated lab testing, we noticed that very few patients had persistently elevated potassium levels on all their measurements. As shown in the bar graphs examining the prevalence of hyperkalemia as a function of the proportion of all lab tests in the patients, about 60 to 75% of these patients had an elevated potassium level only less than once in 4 laboratory tests. This could have happened because of treatment, of course, of hyperkalemia, or because of natural fluctuations in serum potassium as a result of homeostatic mechanisms. In light of these findings, it is perhaps not surprising that when we examine the trajectories over time of serum potassium values that were averaged quarterly in the same study, we saw a surprisingly flat trajectory with no increase in potassium as patients approached the need for dialysis. This happened despite the concomitant increase in the frequency of individual transient hyperkalemic events as kidney function declined, pointing to the presence of substantial variability in potassium concentrations in individual patients. The clinical significance of this phenomenon is still unclear. As previously mentioned, there are various patient characteristics that increase the risk of hyperkalemia. This slide summarizes such risk factors, showing data from a large meta-analysis study that involved over 1 million patients. As you can see, low kidney function and diabetes are very important factors, along also with race and with various medications such as ACE inhibitors or diuretics. Patients on dialysis represent an especially high-risk category, given that they don't have kidney function to help dispose of potassium. This slide summarizes the pre-dialysis potassium concentrations measured in dialysis patients treated in different countries who participated in the DOP study. We can see that patients in Russia had the highest levels and those in the US had the lowest, but differences were not that large. Finally, let's turn our attention to the clinical presentation characteristic of hyperkalemia. Most patients with hyperkalemia, especially when it is mild, remain asymptomatic, although subtle signs may occur, and these become more prominent as the potassium levels rise and hyperkalemia becomes more severe. These include symptoms such as muscle weakness and constipation, but clinically, by far the most important presentation is the development of cardiac arrhythmias. This slide summarizes the main EKG changes that one might expect with rising potassium concentrations, starting with a peak T wave and then progressing to widened PR and QRS intervals, and finally a sine wave pattern. Note that EKG changes may not correlate closely with serum potassium concentration, since electrophysiology is affected by other concomitant factors. An abnormal EKG should raise alarm bells, though. And here is a nice example from a case report showing a sine wave EKG in a patient with severe hyperkalemia, which normalized after receiving intravenous calcium. Because of the known electrophysiologic effects of abnormal potassium concentration, which by the way include both hypo and hyperkalemia, it is not surprising that numerous studies have linked these abnormalities with adverse clinical outcomes. This slide summarizes the result from the same large meta-analysis that we discussed earlier, showing a U-shaped association for potassium concentration with all-cause, with cardiovascular mortality, and with ESRD. Similar U-shaped associations have been described in patients receiving chronic hemodialysis, as shown in this slide. Because we are hypothesizing that hyperkalemia exerts negative effects primarily through its electrophysiologic effects, it is important to examine if abnormal potassium is also associated with a higher risk of arrhythmias. There are much fewer studies that can examine this. One example is this study performed in DOPS, which indeed confirmed that higher potassium concentration was associated with a higher risk of arrhythmias in dialysis patients. In conclusion, we discussed that the kidney plays a crucial role in maintaining normal potassium homeostasis, that hyperkalemia is uncommon in the general population, but becomes more frequent as kidney function decreases, and finally, that hyperkalemia causes cardiac arrhythmias and is associated with increased cardiovascular morbidity and mortality. Thank you for your attention.
All right, fantastic. So today we're going to talk about potassium homeostasis. And we're going to start with a case study. So this is a 52-year-old African-American male who presents with muscle weakness and a serum potassium of 6. The patient is notable for having CKD stage 4, hypertension with blood pressure of 180/92, type 2 diabetes, and he is constipated. His medications include a RAAS blocker for his hypertension and, of course, insulin for his diabetes. What would you consider doing next? Would you discontinue his RAAS blocker for the patient's hypertension and find a replacement therapy? Would you initiate dialysis because the patient's renal function is declining? Would you refer the patient to a nutritionist to be counseled on reducing his dietary sources of potassium? Or would you continue the RAAS blocker, add a diuretic, treat the constipation, and perhaps even encourage the patient to eat a high potassium diet? So I'm going to let you think about these different choices just for a really brief moment. And there's one of these choices that I think you might find would not necessarily be your optimal choice, but I'm hoping today that I will be able to convince you that it might actually be the right choice. So what we have to remind ourselves is that the normal kidney, a normal healthy functioning kidney, has an incredibly large capacity to excrete potassium and maintain a normal serum potassium concentration. This is evidence from the fact that what happened is that there's this enormous mismatch between what our predecessors, our prehistoric man, consumed versus how much potassium we're actually consuming. In fact, prehistoric man consumed a diet that was predominantly of fruits and vegetables and meats, and he consumed, or she, consumed a diet that contained about 15,000 milligrams of potassium per day. Unfortunately, our diet has now shifted away from this high potassium diet. Of course, the kidney had this incredible ability to buffer against this incredible potassium load. But unfortunately, we've switched from a high potassium diet and a low sodium diet to one that's exactly opposite. We are now consuming a low sodium or a low potassium diet and a very high sodium diet. This is a fantastic series of different experiments to demonstrate the ability of the normal kidney to handle potassium loads. These are 4 different experiments. Each one demonstrates that when you give an individual a significant increase in overall dietary potassium, which is represented in the light blue bar from their baseline amount, what we can see is when you look over in the other area, you can see that there's a significant, or there's not a non-significant rise in serum potassium. So for example, with a potassium supplement, there was a significant increase in overall potassium, but if you look at this change in serum potassium, it was modest. This is incredibly important because it demonstrates that you can really push the amount of potassium an individual is consuming and only have modest increases in overall serum potassium. What's even more important, and I will come back to this later in my presentation, is if you look at the individuals that consumed a grain-free vegetarian diet, so they received their potassium supplement in foods, notice that this is the only time when you actually see a slight reduction in serum potassium despite the significant increase in potassium consumption. Again, this is incredibly important, and I will allude to this later in my presentation. So amazingly, potassium is now listed as a nutrient of concern. And it's listed as a nutrient of concern because when you eat a diet that's high in potassium, it actually protects against hypertension, cardiovascular disease, osteoporosis, and the like. It's recommended that as consumers, we should, and with individuals who have normal, healthy, functioning kidneys, that we should consume about 4,700 milligrams of potassium a day. When NHANES and all of these other dietary analyses have actually looked at how much potassium we're consuming, it's found that typical individuals are only consuming about 2,200 to 3,000 milligrams of potassium a day, significantly less than what is recommended for individuals with normal healthy kidneys. But I want you really to focus on the number of milligrams of potassium that normal individuals are consuming. And look at those numbers again. It's 2,200 up to 3,000 milligrams of potassium a day. That's what normal individuals are consuming. Now let's look at the dietary recommendations for individuals with CKD. Notice that we're actually recommending individuals with CKD to consume what everyone is already consuming. I find this to be incredibly important. And I want to emphasize this point that what we need to do is, rather than reflexively instantly tell a patient, oh, stop eating potassium, we need to do a very deep dive into their dietary analysis to determine, are they even eating 2,000 milligrams of potassium in their diet a day? So this is very, very important. And I want to emphasize the point that this suggests then that the average individual is actually consuming a renal or a kidney diet with respect to overall potassium consumption. So again, I think we need to be very, very cautious when we reflexively put on draconian restrictions of potassium. We first need to understand how much potassium is that individual actually consuming. And the reason we need to do this is that there are numerous different health benefits associated with consumption of dietary potassium. It boosts the nervous system, it maintains optimal fluid balance, it prevents muscle cramps, it stabilizes blood glucose levels, it maintains optimal muscle and nerve function. Eating a healthy diet that consumes large amounts of potassium is incredibly good for the health. And I like to use this conceptual model to sort of indicate what happens when we eat a diet that's enriched in potassium. So if you take an individual who has a normal functioning kidney, they consume a diet, perhaps a breakfast that has some orange juice or some relatively high amounts of potassium, and notice what happens. They go from a baseline level, they consume potassium, and notice that the normal, healthy, functioning kidney brings that normal serum potassium all the way back down to baseline. So they start at a baseline, they eat a diet that's enriched in potassium, and the kidney has the ability then to bring the potassium back down to homeostasis. And you can see that this happens throughout the day. What we now do is we take someone who has a dysfunctioning kidney, someone who has CKD, and notice two things. The first thing to notice is that their baseline level of serum potassium is higher. There are now data to suggest that people with CKD are able to withstand a slightly higher serum potassium level, but much more information is needed to be able to fulfill this information. So what you can see is someone who has CKD, you can see that they start at an overall higher baseline level, but notice even though their kidneys are not perfectly functioning, they have the ability after a potassium load to bring back their serum potassiums to their normal baseline, their personal normal baseline. So again, what you see is that some ability to maintain normal potassium homeostasis within that individual, despite the fact that their kidneys are impaired. However, when we then add something such as a RAAS blocker, notice two things. Again, here what we see is that there's a significant increase in overall serum potassium at the baseline level. Now we have exaggerated augmentations whenever an individual consumes a diet that perhaps has potassium, such that we never return to baseline. It's probably these individuals that we most need to worry about with respect to their serum potassium levels. So what is there actually to eat if you're on a potassium restricted diet? Well, pretty much not much. So oftentimes what we think is that fruits and vegetables are incredibly high in potassium, and indeed there are many sources that are. There's also processed meats and the like. But I really despise these types of charts because what they don't tell you is there's so many different ways that the potassium amount in these foods could actually be augmented. For example, instead of having a baked potato, you have a mashed potato. That significantly reduces the potassium content of the food. So I think that what we have to do is be very careful when we just look at these charts. We have to think about how is the food prepared and is the food actually processed. So what we do is we recommend individuals who have CKD to avoid potassium-rich foods. And this is based on the assumption that dietary intake correlates to serum potassium concentrations. We make that assumption, but if you go into the literature, you might not necessarily find that there's strong data to support this connection. Specifically, when we look at where we might see the greatest rise in serum potassium, it's from hidden sources of potassium that can be found in our foods. So specifically, we often tell our patients to reduce their sodium intake, and what do? They probably utilize salt substitutes to replace that flavor. Salt substitutes are absolutely loaded with potassium, so this might be a hidden source of potassium for our patients. Also, what's underappreciated is that there is now a significant amount of potassium additives that are added to our foods. And these potassium additives do not need to be listed on the food label. So oftentimes our patients have absolutely no idea that they're consuming these potassium additives. These additives are found in the preservatives. They're found in flavor enhancers, emulsifiers, thickeners. It's these additives that cause a significant increase in overall serum potassium levels. And why do I say that? Well, there's actually data to suggest, and also just normal food homeostasis, is that when you actually consume a food that has potassium in it, such as if you consume a banana, that banana also has carbohydrates. You have a banana that also has the carbohydrates, which stimulates a small increase in your glucose level. This small increase in your glucose level stimulates an endogenous release of insulin. That endogenous release of insulin actually enhances potassium intake into the cells, as well as enhances extrarenal disposal of the potassium load. So what I'm trying to indicate here is when you eat foods that have potassium in them, you have this normal homeostasis that occurs, such as the nutrients within the foods actually help to modulate the potassium level. However, when you eat a food such that is enhanced with potassium additives, you might not get this endogenous release of insulin, and therefore you would not have this enhanced potassium uptake into the cells. A beautiful study by Alon et al. Demonstrated that oral potassium plus a concomitant oral glucose load significantly attenuated the maximal rise in potassium. So again, what I'm trying to demonstrate is eating foods that have potassium may be completely different than actually having foods that have potassium supplements. There may be a biological difference with respect to overall serum potassium levels. So this is sort of the way that I like to think about it. If the type of diet that we actually recommend for our dialysis patients. They eat a diet that's predominantly meat-based. This meat-based diet is also acid-producing, it's low in fiber, it's low in carbohydrates, and the relative rise in serum potassium may be significantly higher. If our individuals actually eat a plant-based diet, this plant-based diet would be higher in carbohydrates, higher in fiber, to actually stimulate the colonic homeostasis of potassium that is often underappreciated, as well as it's also net base producing. So the idea is that perhaps the bioavailability of potassium differs based on the type of food that one individual may be consuming. So this is the idea, in which is we have to go in and actually do a deep dive into the actual diet of our patients, which is asking them what types of foods are they consuming, so that we can really get a better appreciation of what's happening with respect to their own body's response to the types of foods they're eating with respect to serum potassium. So here's a study that actually demonstrates that consumption of a plant-based diet, one that contains potassium, is actually associated with lower mortality in individuals with CKD. So this is quite opposite of what many of you might predict. And this is again saying our patients with CKD might enhance or reduce their overall level of mortality by eating a diet that's enriched in potassium. This is a fabulous study that indicates that, if you actually take individuals who are on dialysis, you significantly increase their overall potassium intake from 500 milligrams up to 4,500 milligrams per day. What you can see is there's a modest correlation between this significant increase in dietary potassium and their serum potassium levels. Again, suggesting that even though these individuals are on dialysis, they may be able to handle a significant increase in potassium intake, especially if it's coming from a dietary source. So how do we measure dietary sources of potassium? Well, we do it in several different ways. The ways that are probably the most inaccurate is that we can do food frequencies, we can do dietary recall, but this doesn't necessarily tell us how the food was prepared, doesn't tell us about the processing, and doesn't tell us necessarily about whether it was boiled and the like. So what the best way to actually determine potassium levels is to do a 24-hour urine collection. And to emphasize this point, this is a fabulous study that was actually looked at urinary potassium secretion and clinical outcomes in patients with CKD. And again, what they found was that those individuals who consumed the highest amount of dietary potassium, as reflected as the highest level of urinary potassium secretion, they had the lowest level of mortality. So again, suggesting that even in individuals with CKD, consumption of dietary potassium is very, very healthy for them. So this is just to say that what we want to do is we want to have more studies that actually look at the correlation or the association between increased potassium intake and what happens with respect to cardiorenal outcomes. There's many studies that have been done in the general population with individuals with normal functioning kidneys. But what we want to do is we want to have more of these studies conducted in individuals with CKD or ESKD. This is imperative because many of the old studies that were done were actually done with potassium salts or potassium supplements. And what they ended up doing was taking individuals that had CKD or ESKD and actually gave them significant amounts of potassium in these salts, and then they measured their relative raise or change in serum potassium. What I'm arguing is that there might be a difference with respect to dietary foods that contain potassium and the relative rise in serum potassium, and these studies have yet to be conducted. There is one study that actually we are looking forward to looking at the results. The results will be out in 2023, but unfortunately this study is exactly like the previous studies where they're using potassium chloride or potassium citrate supplements in individuals with CKD. Again, I would argue that another study that absolutely needs to be conducted is to do exactly this, like this study, only give these individuals potassium supplements in the form of foods as opposed to actual supplements, and see what the change in overall serum potassium is in these individuals. So just to summarize then, dietary potassium intake is a modifiable risk factor for individuals with decreased kidney function. Strict reduction of potassium in patients with kidney impairment may adversely impact nutrition and contribute to worsening outcomes, as represented in some of those studies. Epidemiological analysis in a majority of studies indicates that high potassium intake was associated with cardiorenal benefits in CKD patients, again suggesting this positive association with high potassium and benefits even in individuals with CKD. in CKD and ESKD patients receiving a RAS blocker therapy who are at high risk for developing hyperkalemia, dietary intervention alone may not be sufficient. And we're going to hear about today some of these more novel new binders that may actually be beneficial for these individuals who have CKD, who would like to eat a diet that is enriched in plant-based foods and also are on a RAS blocker. Again, there's this promising hope for individuals with CKD to overall enhance their nutritional quality. So with that, I'd like to end and thank you very much. Thank you.
Hello, my name is Roberto Pecoits-Filho, and today I'm going to be speaking about the renin-angiotensin-aldosterone system inhibition, optimization, targets, and optimal kidney protection. So this slide is a nice way of starting this, and this displays the strategies that we currently have to protect the kidneys in diabetic and non-diabetic kidney disease. So on top, you'd see the non-pharmacological approaches that provide evidence-based recommendations of what should be prioritized. So smoke cessation, exercise and weight loss, and reduction in sodium intake are the measures that need to be implemented with the intention of reducing the risk of kidney disease progression. Then on the bottom, you see the main strategies that we'll need to take: blood pressure control and glycemic control in diabetic patients. And those are the therapies that are recommended for kidney disease protection. Today, during this talk, I'm going to be focused on the renin-angiotensin-aldosterone system inhibition as an important strategy to reduce the complications of diabetic and non-diabetic kidney disease. And I'll also give a focus on the main complications related to this therapy, namely hyperkalemia. A lot of the things that I'm going to be discussing today are based on the recently published guidelines revised by KDIGO between the years of 2020 and 2021. The two most recent ones that will be discussed today would be the management of diabetic kidney disease and also the blood pressure management in patients with CKD. And if we start with the management of blood pressure in patients with kidney disease, a lot of the motivation for revising these guidelines recently was based on recent publications like the one we see in front of us now. So this is the main results of the SPRINT study. More specifically, the main results related to the about 30% of patients involved in the studies who had chronic kidney disease. And this is the analysis published at JASN a few years ago of the main outcomes in SPRINT for the subpopulation of patients with low GFR and albuminuria. And you see here that especially for all-cause mortality, you see a very significant reduction in this outcome for the subset of patients with CKD when treated to a target of lower than 120 millimeters of mercury of systolic compared to the standard BP control that was systolic blood pressure lower than 140. So now going into the specific management that patients included in SPRINT was submitted to, I wanted to bring you to this algorithm for the treatment of patients included in that trial, just to highlight how patients were followed up and how targets were recommended in the trial. So investigators would have a target of a systolic lower than 120, and in monthly visits, this target was revisited and medications were added as needed. It's important for the focus of this talk that there was a clear recommendation that multiple drugs would be necessary in that trial. And one of the important drugs recommended as a first-line therapy for the SPRINT trial was the RAASi inhibition, including ACE inhibitors and also angiotensin receptor blockers, or ARBs. And when we look at the results of this, particular patients in SPRINT using ACE inhibitors compared to placebo, you see here not only in SPRINT, but also in all the trials revised by the evidence review team working with the KDIGO working group. You see here the main events and the reduction in events for the patients using ACE inhibitors compared to the standard of care. And you see that particularly for cardiovascular events, for ESKD events, and also for the composite of ESKD and doubling of serum creatinine, there is quite a good certainty that ACE inhibitors compared to the standard of care provided patients a benefit in terms of fewer events. Now, the main limitations of protocols like that used in SPRINT and other trials focused on the prevention of the progression of kidney disease is the occurrence of hyperkalemia. That has been described as a main limitation for the use of RAASi in different randomized trials in patients with chronic kidney disease with RAASi interventions. And you see here for the ASK trial, for the J-LIGHT, for the RENAUD, and for the IDNT, all presenting a significant rate of hyperkalemic events ranging from 5 to 20%. And for that population, the risk is justified by what we can see here in this slide that lists the main risk factors for hyperkalemia. So obviously patients with reduced in GFR, especially more advanced kidney disease, the use of potassium supplements or salt substitutes are not recommended. But if you look at the description of diseases related to hyperkalemia, you see right on top patients with low GFR. Also, patients with higher albuminuria are at risk for hyperkalemia, diabetic patients, and on the right side of the panel, you can see here the RAAS inhibitors are clearly a medication associated with the occurrence of hyperkalemia episodes. So if you put all of this together, understanding what kind of patients we treat, aiming to controlling blood pressure and introducing strategies, including RAASi inhibition, are pretty common in clinics with CKD patients. Now, this comes from the the management of diabetes in patients with CKD, KDIGO recommendations published last year. And it shows an algorithm that is recommended to initiate and to keep monitoring patients with an ACE on an ARB therapy. You see here that two things that are important in patients initiating ACEs or ARBs. One is the monitoring of serum creatinine, just to try to capture large drops in GFR. And the recommendation, as you can see here in the right side of the slide, is that patients should be monitored for GFR drops. And even in patients with larger drops in GFR, strategies to check what the underlying problem that might be associated with this should be checked before ACEs or ARBs are discontinued. And in the center part, you see here for the patients developing hyperkalemia, the measures to prevent and control this complication of RAS inhibition initiation should be reviewed, like reviewing the concurrent drugs that might be associated with the hyperkalemia. You can consider advising patients on diet potassium intake and perhaps decrease the potassium intake in diet using nutritional counseling, and also consider concomitant therapies that might mitigate the problem with hyperkalemia, like the use of loop diuretics, supplementation of sodium bicarbonate, and also the use of GI cation exchanger that will be discussed later in this session. That goes to show that really efforts to really mitigate the hyperkalemia problem and to control it, to allow the use of ACEs and ARBs, they need to be used before considering the reduction in dose or stopping an ACE or an ARB, which should be left as a last resort. Now, let's take a look at the real world and see how this risk of hyperkalemia is affecting the use of ACEs and ARBs. So this is data based on the INET-CKD, an International Society on Nephrology initiative that tries to capture multiple cohorts and results in different areas of CKD care. And this publication, led by Natalia Pinho from France, actually describes medication use in different cohorts. They're represented here by these circles. And what you can see here is the percentage of patients using different drugs used to manage hypertension in patients with kidney disease. And let's focus then in the first line to the left, the first column that represents the RAASi therapy in percentages of patients treated in these different CKD cohorts. And you can see here some important information. First is the large variation between patients using ACEs and ARBs in different cohorts. And you see here a dominance of the green dots here that represent the cohorts where more than 3/4 of patients are using ACEs and ARBs, up to some cohorts that about 90% of patients are using RAASi inhibition, which is a big difference compared to some other cohorts like the ones in the bottom here, that represent a much lower use of ACEs and ARBs in patients with chronic kidney disease followed by nephrologists. The green dots here that are more concentrated on the top part of this are mostly European cohorts, while some Asian cohorts and Latin American cohorts, and especially US cohorts, are using much less of this important treatment of the progression of chronic kidney disease, pointing to an underuse of RAASi in some regions of the world. And this is reinforced by the data that we published a couple of years ago based on the CKDOPS study, which is a multinational study. And here you can see data for Brazil, France, Germany, and the US. In the bars, you can see different stages of chronic kidney disease from 3A to 5. So what you can see here, and let's focus on first the differences between countries, that in European countries included in CKDOPS, France and Germany here in the case of RAASi inhibition percentage of patients utilization, you see that there's no major change in the percentage of patients on ACEs and ARBs, even in patients with more advanced chronic kidney disease in France, which is a pattern that is different from what you can see here in the left part for Brazilian patients and also for the US patients. The second thing is focusing particularly in the US, and this is a real world study that shows that in clinics run by nephrologists in the US, you see that even in patients with more preserved kidney function, only 60% of patients are under an ACE or an ARBs. And more strikingly, you see here that if you move to more advanced kidney disease, like stages 4 and 5, the percentage or use of ACEs and ARBs in patients with chronic kidney disease under nephrology care goes down to less than 50%, pointing to a major problem related to underuse of these life-saving therapies for a population that really deserves uses, especially in some countries of the world. Now, what are these numbers pointing to? And I think one of the main impressions that we have looking at this data in different countries is the fact that as GFR goes down, hyperkalemic events become more prevalent, and they lead to a suboptimal RAASi treatment. And once a patient has a RAASi inhibition discontinued, it's very likely that in the future, patients are not going to go back to that type of treatment. So you can see here in a large cohort of US patients with hyperkalemia recorded, you see here that the percentage of hyperkalemic events leading to a reduction in dose in the light blue or in purple, a discontinuation is quite high, especially for patients with moderate to severe hyperkalemia. A hyperkalemic event leads to discontinuation or down titration is about 50% of patients, which confirms the information that we just discussed related to the decreasing use of ACEs and ARB as GFR goes down. And finally, just one slide to bring an important point, which is the clinical consequences of suboptimal doses or discontinuations of patients who should be using RAASi inhibition. So this is, again, data from a large cohort of patients with different comorbidities. And let's focus here on the left part of the slide. We show the population with chronic kidney disease, group 3 and 4, meaning patients with lower GFR lower than 60. And you can see here, in terms of the experiences of adverse outcomes or mortality that these patients have, you see here that patients who are on optimal doses of ACEs and ARBs, they have a much lower mortality and poor outcomes rates compared to patients who are taking a sub-maximum dose, and even higher rates for patients discontinued, showing that this discontinuation of a RAASi inhibition strategy seems to be associated with poorer outcomes in patients who do not tolerate. And this is being confirmed in other cohorts in different parts of the world, and will be confirmed by a prospective randomized controlled clinical trial that is ongoing in the UK. So finally, I just wanted to point out before I close an initial reaction to the current scenario and the current recommendations that are coming up in the diabetic and non-diabetic CKD population with the publication of the revised KDIGO guidelines. And first of all, this publication that just came out trying to understand the size of the problems of patients that are needing to be targeted to a lower blood pressure target of 120 of systolic, and also the use of ACEs and ARBs that seems to be a problem that over time is not being solved and actually getting worse with tighter blood pressure controls and the higher evidence behind the importance of ACEs and ARBs in the prescription. Meaning that patients that are requiring those target recommendations are increasing over time. And finally, also based on a population of patients in a United States cohort, the fact that the underuse of ACEs and ARBs seems to be something that is constant over time and is not really improving even with the dissemination of evidence-based guidelines. So with that, I want to close my presentation with the main conclusion, that is that hyperkalemia contributes to a significant mortality, and limits of cardioprotective and renoprotective RAS inhibitions are important things that we need to think about the implementation of the new recommendations to try to reduce the rate of complications in that population and also improve the kidney disease progression protections therapies. And with that, I thank you for your attention. I'll be happy to take questions at the end.
Hello, everyone. My name is Manish Sood. I'm a nephrologist and epidemiologist at the Ottawa Hospital in Ottawa, Canada. Thank you for allowing me the opportunity to speak to everyone today. Today, I'm going to discuss the emerging evidence in potassium management. This is a very hot area with rapidly changing evidence, and hopefully we can bring you up to speed with this brief PowerPoint presentation. A quick conflict of interest of mine is I have received a speaker fee from AstraZeneca, just so everyone knows. So quickly, the things that we're going to discuss today are new and emerging fields and the evidence in the management of hyperkalemia. This is the outline of what we're going to discuss. So I'm going to talk about some real world data studies, kind of a boots on the ground, what's really happening when clinicians are managing hyperkalemia in the outpatient setting. Then I'm going to move over to one of the more commonly used treatments, which is SPS, sodium polystyrene sulfonate. I'm going to go over some recent evidence on the safety of this medication. And then lastly, I'm going to talk about our newer potassium binders and review some of the existing evidence, the indications for their use, and more focus on emerging data of newer studies that are coming out with the use of these agents. So the reality is, what exactly we do for the management of non-emergent hyperkalemia is a little unclear. So you can imagine we have a lot of options potentially, but what really is being done on a day-to-day level, we don't really have a good setting for it, and there are no randomized control trials to guide us. Because of this, our research group looked to examine what are common outpatient, non-emergent hyperkalemia management strategies. We looked at roughly just under 50,000 people over the age of 66 who had a potassium measure of greater than 5.3 as an outpatient, and not an emergency room. And these people were on a RAASi inhibitor, such as an ACE or ARB. And we looked at the following treatment options. What was done most commonly for these people? The options were to discontinue the RAS inhibitor, to dose decrease the RAS inhibitor, to add in a new diuretic, to increase the diuretic dose, or to add sodium polystyrene sulfonate, or SPS. And the questions, again, as we were interested in, are what are the common treatment strategies that are being done in the real world? And were any strategies associated with risk of hyperkalemia recurrence at 1 year? What we found that of people who had an outpatient measure of potassium greater than 5.3, about 1/4 had a change in their long-term medication. And the most common medication prescription change was that they had their RAS inhibitor discontinued. 74% had that done. The next most common was RAS inhibitor decrease 15%, diuretic increase in 7%, a new diuretic in 3%, and SPS prescription in 1%. Our findings that RAS discontinuation was the most common strategy for outpatients with hyperkalemia has been reported in other papers as well. How about the risk, 1 year risk of recurrent hyperkalemia based on the treatment strategy? So here we did some adjusted models and we looked, and I just want to focus your attention. This is a graph showing the cumulative incidence of recurrent hyperkalemia over the following year. The highest risk was for this purple dashed line, which was RAS discontinuation. The highest risk was for this dashed line, which is new SPS reaction or prescription. So those who were given a new prescription for sodium polystyrene were at the highest risk for a recurrent episode of hyperkalemia. We can only speculate the reason why. Perhaps it's intolerability with the medication. Perhaps it was a short prescription length. We didn't really look at the factors behind it, but this is what we saw. The risk was adjusted hazard ratio of 1.30. And then when we looked at what treatment strategy was associated with the lowest risk of recurrent hyperkalemia, it was RAASi discontinuation, adjusted hazard ratio of 0.82, and that was statistically significant. Now, I'm by no means endorsing that we should be discontinuing RAASis in patients with hyperkalemia. These medications, ACEs and ARBs, have cardiovascular and renoprotective benefit, and this has been shown in large randomized controlled trials. However, what this study is showing in the real world, when clinicians are being faced with hyperkalemia, non-emergent, what they're doing is discontinuing RAASs because they work. They're not associated with a higher, or they're actually they're associated with a lower risk of recurrent hyperkalemia. Now, a lot of us are familiar with potassium binders in general, but just quickly, the idea here is that you will ingest this potassium binder. It is relatively inert in the GI tract, where it will bind potassium from the diet, and you will excrete this through stool. The most commonly used is, as I mentioned, SPS, and it was first approved by the FDA in 1959. So you can imagine this drug has been here for a long time. People have a lot of familiarity with it. Roughly about a few years ago, the last time I looked, greater than 5 million doses of SPS were prescribed in the US per annum. But because this drug was approved 60 years ago, the standards of acceptance in those days were much different. So there's very little actual randomized controlled trial evidence on this drug's efficacy. If we look at the standards of trial design that we accept now, really there's only one trial that has looked at 30 people per arm, and it was for a very short period of time, looking at the effectiveness of this drug. Ever since this drug was first introduced, there have been an accumulating series of not only basic science studies, animal studies, case reports, and case series of GI injury related to SPS use. A lot of these were occurring previously when the drug was administered with sorbitol, which is a powerful laxative. But since the FDA issued a warning about its co-administration with sorbitol, the injury reports have continued. So it seems to occur independent of sorbitol. Now, to better characterize the risk, we carried out a population level study where we looked at 20,000 outpatients who received a prescription for SPS. We matched these people to 20,000 patients with no risk of SPS and looked at the 30-day risk, so a short window, 30-day risk of presenting to the emergency room or be hospitalized for a GI injury. And this GI injury we put as upper GI tract or lower GI tract. Now, I know often intestinal necrosis is the most commonly reported GI injury, but there have been a number of studies that have shown esophageal injury is possible as well. What we found was that among people who were given a prescription for SPS, there was a small but consistent, statistically significant risk of GI injury. The absolute risk was 0.2% versus 0.1% in the non-SPS users. This turned out to be a rate of roughly 23 per 1,000 prescription years. And the adjusted hazard ratio for this risk was 1.94. Now, our study was limited to mostly people who were not on dialysis. There were a few people on dialysis, but very few. When we looked in subsequent studies that have been now published, the risk in dialysis seems to be conflicting and unclear, and it has not still been fully characterized. The takeaway message of this is that we should have caution with the use of SPS. There is a well-documented, characterized, small but significant risk with GI injury. Now, with all these things being considered, there are a number of now newer potassium binders available for treating hyperkalemia in adults, with the two main ones being sodium zirconium cyclosylate, which goes under the trade name Lokelma, or Patiromer Sorbatex calcium. Now, Patiromer was approved for use in 2015 for non-life-threatening hyperkalemia. There's no renal dosage required with this. And what it has demonstrated is a dose-dependent decrease in serum potassium. So some other further properties are for people with larger serum potassiums who take this medication, it seems to give you more bang for your buck. You get a larger drop. And people have now taken this drug daily for up to 52 weeks in studies. So we have a long window of exposure and safety. The most common side effects reported are GI related as expected. But the other one to mention is hypomagnesemia, which occurs in about 5.3%. And we should always remember to monitor magnesium levels in patients we are prescribing patiromer. The onset of action of this drug is roughly 4 to 7 hours, and we have good studies illustrating the effects over time. This is an example where you get very slight decrease in serum potassium 4 hours after a dose is administered. If a second dose is given, you get further decreases, but the onset is a little a slower side, with peak effect being seen around 40 plus hours. There have now been a number of randomized controlled trials with patiromer showing it is effective in reducing serum potassium in patients with chronic kidney disease. As well, it's been shown that it is effective in patients with congestive heart failure and spironolactone. A very recent trial that has been published, the AMBER trial, examined patients who have quite advanced CKD, GFRs 25 to 45, and resistant hypertension. And the strategy there was they randomized 574 patients to spironolactone for treatment of the resistant hypertension, likely due to hyperaldosterone, plus patiromer versus spironolactone plus placebo. The endpoint was the percentage of patients who were able to stay on the spironolactone, with the idea being a number will have to be stopped due to hyperkalemia. The main outcome at the end of 12 weeks, 86% were able to stay on spironolactone with the patiromer versus 66% who received the placebo. If you look to the graphs to the slides, the lower slide is the risk of hyperkalemia, and the blue bar is the blue line is those who had placebo, and you can see it's much higher than the people who received patiromer. How about SZC or Lokelma? This was approved for use in 2018, and again for non-life-threatening hyperkalemia. It also shows a dose-dependent decrease in serum potassium with kind of more bang for your buck. The higher your pre-dialysis or your pre-dose potassium is, the more decrease you will have as you take the drug. It works in a quite nice dose-dependent fashion, which is illustrated by this figure. What you're seeing here is a group of patients who had potassiums around 5.6, all received patiromer, lowered their potassium. Then they were treated with either placebo, 5 grams of Lokelma, 10 grams or 15, and you could see very clearly a nice distinction in their serum potassium level based on the dose that they received, with the biggest decrease in the 15-gram group. The major side effects with this medication are edema. There's about 400 milligrams of sodium per 5-gram dose of Lokelma. Other effects are also hypokalemia, constipation, nausea, and diarrhea. These drugs have now been studied as well, being taken daily for up to 52 weeks. One of the differences between the two drugs is it appears SSZ has a more rapid onset of action, where you're seeing drops in serum potassium within an hour. And so after a single dose, by about 4 hours, you will get about a roughly half millimole decrease in your serum potassium. So it does appear to be working more quickly. Now, there have been studies showing this medication is effective in patients with chronic kidney disease and CHF. One of the more emerging trials, the newer indications that is actively being studied, was published in something called the ENERGIZE trial. And this was patients presenting the emergency room with high levels of potassium, emergent hyperkalemia. So this is a mean potassium, the patient population had a mean potassium of 6.5. They were randomized to a strategy of insulin plus glucose plus Lokelma, and they were given up to 3 doses of 10 grams, or insulin plus glucose plus placebo. They randomized 70 patients, and the primary outcome was change in potassium levels. What they found was with Lokelma at the 4-hour mark, there was a larger decrease in serum potassium of roughly 0.4 milliequivalents decrease with Lokelma versus 0.27 with placebo. And there was even a larger effect at the 2-hour mark where they got a decline of roughly 0.7 milliequivalents versus placebo, which was 0.36. Now, rescue therapy, additional therapies required to lower potassium, was much lower with the SZC group, 15.6% versus the placebo group, which required 30% to receive an additional therapy. A further area of expansion for Lokelma is in the hemodialysis population. They published a trial now called DIALYZE, which is a randomized controlled trial of patients receiving thrice-weekly hemodialysis, and they were randomized to receive Lokelma versus placebo if they had a pre-dialysis potassium greater than 5.5. And what we saw in the population receiving Lokelma was illustrated here. You could see their pre-dialysis potassium, which is the left-sided graph, the upper line, decreased from around a mean of 6 to a mean of 5, and the lower line represents their post-dialysis potassium. Now on the right-hand graph, what you see is a placebo group whose pre-dialysis potassium just hovered close to the 6 range with no decrease. So effectively, what they were able to show is the use of this medication, you're able to reduce the mean pre-dialysis potassium by roughly a millimole. Now, lastly, pulling this all together, some summary and recommendations are, what we're seeing in the real world data is that RAASi discontinuation is the single most common strategy for patients who develop hyperkalemia on RAASi. And it's not a really big surprise why this is being done. It works. And that's what we showed. It's that it's associated with the lowest risk of recurrent hyperkalemia. But the problem is you're trying to fix the short-term issue, but you're losing out on the long-term benefits of cardioprotection and renal protection that occur with ACEs and ARBs. Now, for currently existing binders, SPS is the most long-standing, commonly used binder, but there's really little evidence to guide its use. There's a lot of uncertainties regarding its efficacy. And more recently, there is a pretty clear GI safety risk that is occurring. So I would recommend caution with its use and to avoid it if possible. We've entered the modern era of potassium binders, and we have now 2 agents that are well studied with many active investigations ongoing. There are a lot of indications in specific patient populations and newer studies that are emerging. For example, patiromer recently shown in patients with CKD and resistant hypertension. It facilitates spironolactone use. Whereas Lokelma has now shown evidence in the dialysis population and reducing the pre-dialysis serum potassium and expanding to areas of emergency hyperkalemia management. One big area in the evidence is that we still lack direct comparisons between SPS or potassium losing diuretics versus some of these newer binders. You can imagine there are going to be some challenges if these studies are to be done. For example, is it ethical to randomize people to SPS knowing that there could be potentially fatal GI injuries, albeit rare, but they're there? Secondly, with diuretics, they may not be suitable for all patients. If you recall, one of the most common mechanisms for hyperkalemia is in patients who might have a slight acute kidney injury and they may have lowish blood pressures. Whether diuretic is suitable in that situation is likely still not clear. So with that, I'd like to thank everyone for their attention, and I'll bring our discussion to a close. And of course, we welcome your comments and questions. Thank you.
Well, thank you, everyone. They were a wonderful set of talks, and I certainly benefited a lot from hearing that breadth from the the essential physiology of potassium management right through to the latest trials. So we have the panel assembled, and as well we have Dr. Palmer who will join us, and thank you for participating in the panel discussion. We have a number of questions coming in, and I'd like to encourage all the audience to put any questions that they have into the chat box, and we can get the panel to give their views and suggestions and answers to those. One question that I have, which I'd like to ask each of the panelists, and I'll give you a little bit of notice to think, is what is the single most important remaining research question? So we'll take a few more straightforward questions first, but I'd like you all to think about that, and I'll come back to you for your response. So the first question that we have coming in from the audience is going back to the use of ACE and ARB. How safe is it to use ACE and ARB in hemodialysis patients? And if I could add, what would you do differently in managing hemodialysis patients on ACE inhibitors or angiotensin receptor blockers? Perhaps Roberto, you might be best suited to take that question.
Yeah, sure. And I think it's a great question because similar to what I described about underuse of agents in the non-dialysis population, I think there is clear evidence that in dialysis population with a very high risk of cardiovascular disease and the high prevalence of heart failure as a comorbidity, for instance, I think if we look at the usage of cardioprotective drugs in dialysis patients, we see clear underuse too. That's true for beta blockers, for instance. But I think there's a clear role for RAS inhibition in dialysis patients, mainly to reduce the cardiovascular risk in that population, including, a good amount of observational data showing that the use of ACEs and ARBs, especially in patients with the characteristics of heart failure, with or without low ejection fraction, and I think optimization of that treatment in that subgroup of patients is a strategy that would be advised. Also, there's, at least in the peritoneal dialysis population, there is evidence from RCTs that ACEs and ARBs are associated with lower loss of residual renal function in the future compared to placebo, which is also a benefit that we should think of, not only in PD, but perhaps also in hemodialysis patients, although there's no evidence. We actually don't monitor residual renal function that much in hemodialysis, and that might be another thing to discuss. So I think in general, there is a role, and it seems like, in dialysis patients that the use of ACEs and ARBs is a safe measure. And perhaps with the loss in residual renal function, the association between RAS inhibition and hyperkalemia might be lower than what you would see in patients without dialysis.
Oh, thank you. Yeah. Could I now ask, perhaps Dr. Palmer might take this question. I'd like to ask a little bit about the use of, not restricting potassium, maybe even we'd say potassium-enriched diets in patients with CKD. I think Dr. Clegg's comments about the potential differences in the effect of dietary potassium versus potassium supplements was a good point, and maybe one that not many people think about. Do you think that the renal community is ready for this, or do you think we need to do some more work first?
Yeah, I mean, thank you for bringing that up. When I think a big point of Dr. Clegg was that we need to be a little bit more nuanced in how we restrict dietary potassium, as opposed to just making a blanket statement to reduce all of these foods that happen to be enriched in potassium. I think the points to be made, and perhaps less well appreciated, is that, for example, foods that have a lot of fiber have a lot of potassium, but it turns out that the bioavailability of that potassium is a lot less. In other words, you absorb a lot less of it in the setting of a high fiber content. By contrast, a fruit and vegetable with much lower fiber content the bioavailability is probably much greater. So in other words, I think we can be a little bit more nuanced as to how we make these recommendations. And I'll just kind of jump ahead and give you the answer to your question that you posed. I think a very striking study that would be of utility is, could one actually augment dietary potassium intake and utilize some of these new binding agents as a way to prevent hyperkalemia? And, you know, is that, number one, feasible? But number two, would it actually lead to things like improvement of quality of life? You know, we tell particularly advanced CKD and dialysis patients to restrict so many things in their diet. Might this be a way that you could liberalize and actually have an improvement in quality of life?
So that's a great question. So you would do a study of a potassium-enriched diet with a binder, not the potassium-enriched diet on its own.
Yeah, I mean, it's just kind of an interesting thought.
Yeah, no, it's a terrific question. All right, now Dr. Wong has jumped in early actually with a question. So this is obviously an important one, which maybe Manish, you could take, which is about when we commence these novel potassium binders, what your suggestions are for monitoring the potassium, how early and how often, and what are the situations in which they should be discontinued, or are you essentially starting these binders and continuing for life?
Great questions. Thank you for that. So the starting dose for patiromer is 8.4 grams per dose once a day. And for Lokelma, it can be anywhere from 5 to 10 grams TID. And a little bit of the decision on which exact dose to start will depend on the potassium level you're seeing. But let's say it's a moderate level of hyperkalemia, somewhere in the 5.5 to 6 range. Then starting at the lowest dose with slow up titration is a very reasonable strategy, assuming the patient is fully stable. And you can monitor your K levels depending on how high the pre-potassium is, up to every 2 to 5, 7 days, and continue to titrate up accordingly. Now, if you are using, for example, patiromer, you do want to keep in mind that magnesium, hypomagnesemia is a complication. So you may choose to measure that at least the 1 week mark or further down the line. And both of them can actually lead to hypokalemia because of their effectiveness. So it's another reason to monitor. Once you have achieved a normal kalemia level that you are satisfied with, you can down titrate from a dose that you're at to 1 step lower for maintenance therapy. So that is kind of following what was done in the trials and seems to show long-term efficacy in maintaining low potassium. May I also answer my dream trial question and comment as well? Because thank you. So one, just to mention Dr. Palmer's excellent suggestion, there are registered on clinicaltrials.gov trials with both of the newer agents looking at the feasibility of liberation of your diet. So people are on a low K, low healthy renal diet, and then they start taking these agents, and then they slowly are delivered food packs of fruit and vegetables with known potassium contents, and they're going to look whether it can maintain the potassium in a normal kalemic range. So those studies are ongoing, and you know, we're all eagerly going to be awaiting at least some of these early feasibility trials. If I had to choose a head-to-head to design, it would be the comparator between some of these new binders versus a diuretic such as a Lasix or thiazide. I think that would be a very interesting trial to be done. And I think we need to have, most of the studies that have been done to date are placebo comparators, not an active comparator. And I think in day-to-day practice, for some scenarios, we do use diuretics to reduce serum potassium. So I think it would be an important comparison study. I would not be advocating probably for SPS as a comparator. I do think there's significant GI concern that I just don't think it would be the appropriate medication to be randomized to. Thank you.
Oh, thank you. Thank you. There are a couple of questions that are essentially around the tolerance for hyperkalemia. So if patients are on RAS blockade, can you ride it out, or would you stop in the presence of hyperkalemia and restart? Or the tolerance for adding agents, say, spironolactone plus RAS blockade. So essentially all those questions are probing the tolerance for hyperkalemia, and that the answer to that might be relevant on related to CKD stage. So could I get the panel's responses on that? And essentially maybe Csaba and Roberto, that might lie in your talks.
Yeah, so the first of all, the double RAS blockade has been reasonably well studied now in clinical trials, and it is not recommended as a standard practice. You can talk about Nephron D, you can talk about the DRI, the direct renin inhibitor trials that have looked at this, and in general, what was noticed is a higher risk of acute kidney injury and also higher hyperkalemia rates in patients receiving double RAS blockade. So currently, that is not a recommended strategy. What's threshold of potassium is well tolerated is actually a $1 million question. Us in clinical practice, we're all nephrologists and we see a lot of hyperkalemic patients, so we sort of grow tolerant towards what you would call milder increases in potassium, let's say less than 5.5. But all the observational data that we have from very large cohorts show that there is a linear increase in adverse outcomes above a potassium somewhere around 4 to 4.5, depending on what population you look at. So based on those data, you could hypothesize that even those mild elevations in potassium may be at least associated with adverse outcomes. And to me, it's not necessarily the mild elevation of potassium itself. A potassium 5.1 or 5.2 may not necessarily be causative in a future adverse outcome, but it may be a big red flag to suggest that that patient may have a unmeasured or undetected severe elevation in potassium unless it's addressed. So as a clinician, we probably should be thinking about it that way rather than saying that, a 5.1 is tolerable and that patient is fine. And that kind of gets me to my favorite clinical trial idea, which is basically outcomes. Because we can circle all day the question about which binder to use, but ultimately we still haven't proven that lowering potassium towards normal will result in beneficial clinical outcomes. So a trial of preventing hyperkalemia or maintaining normal kalemia versus a standard of care is something that could go a long way in justifying our probably a rightful obsession with correcting hyperkalemia in our populations. And by the way, those type of trials are also in development. So it gives me real hope that we're not going to end up with a phosphorus-like scenario where for 20, 30 years we've been treating biochemistry without knowing that the outcomes can really be improved. Thanks.
Thank you. No, that's a great suggestion. Roberto, I'll give you your option on the DREAM trial.
Yeah, well, I'll take a different approach, and I'll say that perhaps an important trial in the area that I spoke on is the RCT that is already ongoing. I briefly mentioned during my presentation, but I think the question of benefit and risk of RAASi continuation or discontinuation in patients with very low GFR is an important one. And the Stop ACE trial is actually addressing that. So I think this is a trial that is very useful, that will provide very useful information on a question that is still unanswered and has been, support to keep patients on ACEs and ARBs is mainly on observational trials, and I think an RCT in that area will be very important. And it's upcoming, so that's good news because I don't need to dream or even go for funding for a trial like that because we'll have the results in a year or so.
All right, terrific. Okay. Look, I might just ask one more question if we're nearing the end of our time, but there are a few questions that are coming through on the use of these newer agents in patients on dialysis. does that affect how often you monitor or how often you dose? Perhaps Manish, again, you could take that one.
Yeah, thank you very much. So the DIALYSE trial, which looked at Lokelma, it was given a 10-gram dose on the non-dialysis days. And as it showed in some of the evidence I went through quickly, it did show effective reduction in serum pre-dialysis serum potassium of roughly 1 millimole. Now, there was probably some careful monitoring being done in those patients, but of note, the adverse events were fairly low. So the concern of treatment failure, the concern of rebound to over-treatment and hypokalemia was very low. And as many of you may know, Lokelma is sodium-based. And so one of the concerns is that you might be giving these patients a bit of a salt load, which I know is a constant battle that we have in our dialysis patients trying to achieve effective dry weight. So importantly, the intradialytic weight did not change between those receiving the treatment versus those not on the treatment on placebo. So the parameters were very effective, and it appeared to be quite safe. So to me, that was very compelling evidence for the dialysis population. Now, monitoring itself, I think would have to be based on the level of the pre-dialysis potassium. Again, if you're in the moderate range of 5.5 to 6, maybe after initiating the dose, you do repeated QHD for 2 or 3 runs would be effective. I don't think that would be an unreasonable way. And then you titrate the dosing based on what you achieve.
That sounds good practical advice. Look, there are more questions. There's obviously a lot of interest in this question, and it's a very exciting area with new agents coming on board. But we are at the end of our time, and some of our panelists need to move on to other things. So I'd like to just finally conclude by thanking all our speakers, and in particular thanking Dr. Palmer for stepping in and Dr. Clegg's absence for this panel session. It's been really exciting and a really informative session. I think there will be a lot of continuing interest, so we look forward to hearing the results of the trials that are underway. So thank you, everyone, and thank you to KDIGO for sponsoring this session.